Hello friends, welcome to the session today. We are going to discuss the past papers. So we have pulled up the questions from the past 5 years, the important ones, and we will try to cover as much as possible. If we are not able to cover it on the Friday sessions, I'm going to put it on the app so that you can go through it. So one question that was asked was the cervical spine instability. What is cervical spine instability? What is the clinical criteria to define the instability? What is the spinal segment and the definition of instability? And what is the Canadian C-spine rule? So this the question was divided in two parts. The first two were together, and then was a Canadian C-spine rule. So what is spinal cervical spine instability? That is basically the loss of the ability of the spine to maintain the normal alignment under the physiological load. So as we understand, all the bones maintain the alignment with each other. All the bones are locked with each other. And once the spine is loaded, that is once you stand, once you walk, these are the normal physiological loads when you sit. So if ever the spine is not able to maintain the alignment, that is basically the instability. This may cause pain, deficit, and deformity due to the abnormal vertebral motion. So, because of the instability, what might happen is the facetal joints may get, uh, unstable, and they might rub with each other, which may cause the pain. If they are causing the irritation of the nerve, so that will cause a neuropathic pain as well. Along with that, if the nerve is getting significantly compressed, they might get the deficit and deformity. If ever the bones are undergoing significant destruction, that is when you will get deformity as well. So, what are the different causes? So, A, trauma is one of the causes with which you incur this type of instability. Now, when we talk about trauma, the patients might have fractures or the ligamentous injuries, degenerative changes like disc degeneration and facetal joint arthropathies, inflammatory diseases like rheumatoid arthritis or ankylosing spondylitis, iatrogenic conditions like post-surgical cases, neoplastic or infective conditions that may also incur vertebral body destruction. So these are the different causes in which we incur the instability, which may be associated with significant destruction or not. On the X-ray, how do we see? So this is the anterior vertebral line, which is drawn along the anterior longitudinal ligament. This yellow line is the posterior vertebral line, which is drawn along the posterior longitudinal ligament. Blue line is the spinolaminar line, which is drawn at the junction of the spinous processes with the lamina. And the purple line is the posterior spinous line, which is a bit crooked line, which is not as flowing in nature as compared to the other three. And this particular line basically connects the spinous processes. So this is how four lines should be in place with each other, in relation with each other, and they are continuous and they are not discontinuous. Whenever they become discontinuous, that basically tells that possibly the stability of the spine is compromised, and this is the easiest way on the radiography or on the x-ray that you might be able to determine that. What is the clinical criteria for the cervical instability? White and Punjabi's criteria was given in 1975 and it was redefined in 1990. Still, a lot of references are given which focuses on the mechanical and clinical instability. So, whenever you talk about instability, they're basically divided into two. One is a mechanical element and the other is clinically. Clinically, how you judge when you see the patient. Mechanical is basically how you see on the X-ray or the radiography. So when you talk about the subaxial cervical spine or C3 to C7, if there is a translation beyond 3.5 millimeters or an angular displacement of more than 11 degrees between the adjacent vertebrae, that is instability. Along with that, the atlantodental interval, if ever that is more than 3 millimeters in adults and more than 5 millimeters in children, that is also considered to be some form of instability. Now, whenever we talk about the normal cervical motion at each levels, generally an acceptable range is flexion extension of around 20 degrees. Greatest is at C4556. Axial rotation is from 2 to 7 degrees from at the each subaxial vertebrae, and the lateral flexion like this is around 10 to 12 degrees per level in the segments from C2 to C5, and it decreases caudally with only 2 degrees observed cervicothoracic junction. That is, where, as you go down from up, uh, at this junctional area where the cervical spine goes and becomes a thoracic spine, the mobility, the lateral flexion over there becomes a criteria. So whenever a patient will come to you with a significant that the patient is basically having some form of instability, because a normal patient who is there, that patient may not have a worsening with the activity, or that patient may not have a deformity or an abnormal posture, or that patient may not even have a neurological symptom associated with movement. For example, sometimes the patient may tell you that if ever I bend the neck forward or behind or tilt the neck, I get the pain. So all this is something that is not acceptable, and that basically tells you that the stability might be compromised. Spinal segment and instability. What exactly is a spinal segment? So a spinal segment is basically the area, two adjacent vertebrae and the disc space in between and the ligaments around it, that forms one independent spinal segment. And whenever we talk about instability, that will imply to a biomechanical failure of the anterior column or the middle column or the posterior column. What is anterior column, middle column, and posterior column? So as you see over here, the anterior two-thirds of the vertebral body with the disc spaces in between and the anterior longitudinal ligament is the anterior column. Middle column is basically the posterior one-third of the body, posterior longitudinal ligament, and posterior annulus. So these basically form the post middle column. So why are these columns important? These columns are important because they basically determine the stability and the instability. Because as per the Dennis, whenever the situation is such that it involves two columns, so that is basically not stable and unstable. Similarly, the posterior column is something which involves the pedicles, the facets, the lamina, the spinous processes, and the ligaments over there. So this is the posterior column. So anterior column, the vertebral body disc, anterior one-third with the anterior longitudinal ligament. Middle column will have the posterior part of the annulus, the posterior longitudinal ligament, and the posterior part of the vertebral body one-third as well. Posterior column is the facetal joints, ligamentum flavum, interspinous and supraspinous ligaments. Now, when we talk about the segmental instabilities in cervical spine, atlantoaxial instability is something that is common in rheumatoid arthritis and in patients with Down syndrome. Subaxial instability is the one that is secondary to trauma, and you might have even listhesis in some conditions and degenerative disc disease. So whenever you talk about the instability in the subaxial spine, that most commonly might be because of a injury, because of which the dislocation might have happened, or the subluxation, or in some degenerative conditions. However, when you talk about the atlantoaxial interval or C1, C2, that is the area that is most commonly compromised in some underlying conditions like rheumatoid and Downs. That is the reason why whenever you get patients who are having Down syndrome, you have to rule out the C1, C2 area in regards to the instability. Radiological assessment of instability, you basically get the static and the dynamic X-rays. We most commonly ask for the standing X-rays. Why do we ask for the standing X-rays? Because basically with the loading of the spine in gravity, you actually get to know what is the true condition and what is the situation vis-a-vis the stability and the instability. We do the CTs to see the bony alignment and the fractures. MRI is basically done in only specific cases. These days, yes, it is done in more or less all the cases, but for the theory point of view, MRI is basically indicated whenever you suspect a neurological injury to the spine, you have a deficit, when you suspect the disc might have ruptured, when the ligamentous injury is there and the spinal cord involvement or any involvement above L1 is also there. So in such cases, MRI is recommended. Canadian C-spine rule. Now, Canadian C-spine rule is basically a technique or I would say a guideline that is followed to rule out the patients who basically you receive in the emergency, for you to confirm whether these patients are going to need some form of investigation in the form of radiology or not. Canadian C-spine rule is highly sensitive, more than 99%. It is very much accurate and validated than the Nexus rule. So these are two rules. One is the Nexus and the other is Canadian C-spine. So I would say the sensitivity and the specificity of the Canadian C-spine is way higher as compared to the Nexus, and hence it is way more accurate. It helps to reduce unnecessary imaging in the emergency department, because many a times you might unnecessarily start screening the patients in the emergency when it is not needed. That is why we have the Canadian C-spine rule, to rule out and to clear the patients who basically need the imaging or not. So what are the components of this? So basically, first you have to understand that in which conditions this is not going to apply. So it is not going to apply whenever the patient is not awake or alert or reliable. When the patient is unstable, less than 16 years of age, acute paralysis, known vertebral disease, and previous C-spine surgery. So these are the cases wherein the Canadian C-spine rule is not going to apply. Similarly, whenever you have patients who come to you with RTA, you have to basically put these patients in two categories, whether the injury or the RTA is via a dangerous mechanism or a simple mechanism. So what is the difference? Dangerous mechanism is basically a fall from the elevation more